Welcome. Thank you for joining us today for the second in our Global Resilience Commission meetings, our webinars. Today's webinar is on resilience in the health and medical sectors, lessons learned from COVID, something that obviously we're still learning lessons from, but I'm really excited. We've got a great group to present today. My name is John Heltzel. I'm the Director for Resilience Planning for the Electric Infrastructure Security Council. Just a few housekeeping items this day. If you have questions, feel free to put them in the questions box. We won't try to answer them on the call today, but we will get you an answer back through email or through the follow-up messages that will happen after this. So again, thank you very much for joining us. And let's take a quick look at the agenda. Here we go. We'll be joined today by Mr. Avi Schnur, who's the President and CEO of the ICE Council, what we call the ICE Council, the Electric Infrastructure Security Council. Our facilitator today is Richard Bartlett. Dick is the Emergency Preparedness and Trauma Coordinator for the Kentucky Hospital Association and a longtime friend of the council. We're joined today by Don Boyce, who's in charge of the overall, he's going to present on the overall impact from COVID and talk about a system response, a lot of things that were learned really at the heart of where the COVID initially hit in the United States. We'll be joined by James Blumenstock, who will be talking about building resilience in the health and medical system. And then finally, our last presenter, someone I'm very interested in hearing from, Linda Rouse ONeill, is going to talk to us about resilience requirements in the supply chain and the lessons that have been learned so far. The global supply chain is one of the focus areas for the webinars this fall with the ICE Council and GRCOM. So with that, that's our agenda. Sit back, relax, and enjoy. It's my pleasure now to introduce one of the leaders in the resilience environment worldwide, Mr. Avi Schnur.
Hey, thank you, John, and thanks everyone for joining us today. You know, seeing the leaders in the health sector who are going to be speaking, we had put together a couple of slides that I was going to go through up front, talking about the nature of extreme hazards and focusing on them. I think instead, John, with your permission, we'll just skip through those quickly. And I want to say a few ideas that I think will be particularly appropriate for the health sector and for the leaders who are joining our discussion. So in that regard, COVID-19. So certainly people throughout the health sector live with the tragedy on a very firsthand basis every day. And in today's webinar, leaders that John, you just described will be sharing invaluable lessons learned and best practices. And these are really invaluable lessons learned because the price that was paid over and over again was the lives of all the victims. So it's certainly not a business as usual subject by any means, as all of us are aware. This is a particularly critical dimension then of lessons learned, which today's webinar will help share across the sector, the nation, and the whole world. But I also want to talk to you about the overall vision, where this is going, the vision of the Global Resilience Commission and how the healthcare sector, I think, can fit in. What drove the pandemic overall is globalization. So all sectors, all nations are increasingly interconnected today and therefore increasingly interdependent, really almost on an organic level. So as we're learning, organic interdependency without sufficient resilience is just as dangerous for societies as it is for organisms, and certainly as today's participants will understand far better than most. If you remove any organ from an organism, you risk failure of the whole organism. The same is true for society. COVID-19 has skirted right on the edge of unrecoverable disruption in critical sectors. If that happens, again, without sufficient preparation, the organism, in this case, our society, could collapse. So the healthcare sector is in a key position to drive such preparations. Look, hopefully in the coming year, we will all collectively begin to emerge from this catastrophe And as sector leaders begin to emerge from the nightmare, we will look for an opportunity for a follow-up event, a follow-up webinar, focusing the energy and the awareness driven by COVID to prepare for even more extreme scenarios. Planning for subcontinent scale power and telecommunications outages with extreme societal disruption, that represents perhaps the most extreme set of scenarios we could face. I mean, think about it. As bad as COVID-19 has been and is, imagine going through it without electricity and without water. So the healthcare sector is in a position, as it becomes possible and time becomes available, to use this expanded awareness of hazards to begin driving in this extreme hazard direction as well. And I think can be a real leader among sectors. EIS Council is a leader among both non-government and government organizations in developing tools, capabilities, addressing all scales of such disasters. And we hope everyone involved today will continue to be involved as the series continues and help us and help our partners build planning for a full set of extreme catastrophes. In fact, if you have thoughts on the implications for some of these particularly extreme scenarios, feel free to get them to us through the email that will come out after this webinar. So the product of all the planning will be an evolving Global Resilience Commission framework, which will be briefed worldwide. And if it's done properly and with everyone's cooperation and participation, will create a platform for the broadest possible collaboration to prepare for extreme events. So thank you all for joining us and joining with each other to help make the tragic price we're all paying much more meaningful. John, back to you.
Thank you, Avi. I appreciate that message. It's my pleasure now to introduce our facilitator for today's session, good friend of the council, as I mentioned. Dick Bartlett is going to take over now, and he will direct the traffic for the next several minutes. Over to you, Dick.
Thank you very much, John. Folks, I think it's fairly clear if we've watched the news over the last couple of days that as we approach what many are saying is the second or in some cases the third wave of the COVID pandemic, it's creating some challenges in our industry. And I think that the news that we've seen out of Utah, El Paso, Wisconsin, and in some of our locations over in Europe just demonstrate that we learned a lot during the spring and the summer, and now we're bouncing back and we're applying those lessons again to deal with a new resurgence of that. Early on, I think it was pretty clear for those following COVID news that the New York City metropolitan area was certainly a hot spot. And I think that we're very honored to have today Don Boyce, who is the System Vice President for Emergency Management at the Mount Sinai Health System in New York, who's got some interesting lessons that I think he would like to share with you and we could all benefit from. Don?
Good morning. Comms check. Do you hear me okay, Dick?
Yes, sir. Loud and clear.
Great. Outstanding. And thank you for the invitation to speak this morning. And I'm happy to do so this afternoon here in New York anyway. The first lesson is, as I left my last job at the federal government, this was to be my pre-retirement job. So the lesson is be careful where you go, because coming into a hospital system as a pre-retirement job prior to COVID, not the best step forward. So having said that, an overview of the Mount Sinai Health System is that we're one of the largest academic medical systems in New York City. We have 8 hospitals and almost 400 ambulatory practices with over 7,000 physicians and now over 42,000 employees. Next slide, please. The geographics of Mount Sinai is the island of Manhattan, the borough of Queens, the borough of Brooklyn, and then the latest acquisition is in Long Island, New York. So that is the footprint. A perspective for what we were up against is that, early on, once there was an appreciation for the fact that COVID was a reality and New York was one of the real epicenters, we were projecting upwards of needing over 110,000 beds, over 37,000 of which would be ICU care. New York City has 62 acute care hospitals with a total of just over 23,000 beds combined without their surge capabilities. Mount Sinai has around 2,500 beds without surge. And the question of the day was, where do you find upwards of 75,000 beds? And more importantly, the staff to provision them with little to no notice. Before we really realized it, our blue or gray sky day had certainly turned black and looked like it was going to stay in the black for quite some time. So we started at the very early onset moving forward with the absolute worst case scenario. Next slide, please. So some of the highlights in the timeline here is that we saw and identified in February that we were really getting slammed and up against it. And into February and March, there were closures at the city level. And then in March and April, there were real definitive actions that were moving forward to try and help us address some of our most critical needs. And it wasn't really until June that we saw any lightning at the end of the tunnel. And quite honestly, we've not really taken our foot off of the accelerator at all. We moved from having critical patients in hallways and overwhelming the emergency departments at each of our hospitals using our transportation, which we'll talk about a little bit later, to move patients throughout our hospital system, to then planning for, if it were to come, what a second or a third wave would look like. And we continue to run our operations and logistics calls. We continue to try and acquire our capabilities in terms of PPE, and we continue to move forward as a system in talking and preparing for not only this, but any additional threats that we see on our horizon, for example, domestic terrorism, civil unrest at this point, and what that would look like in the midst of a COVID second or third wave here in New York City. Next slide, please. The evolution of the command structure. This could be a whole presentation in its own right, but what I will say very, very quickly is that we did an exercise in the middle of 2019 that identified, it was the first exercise at a system level. I was here about 6 months. We had identified that we really didn't practice as a system at all. And we saw that the incident management team structure at the hospitals was working very well, but the incident management team design at the system level was failing. And we evolved into an emergency operations center. We did a lot of training with executive leadership through November, December, and into January. And before we really had the opportunity to exercise and test and assess what we did, we were in the throes of COVID. So we utilized the Emergency Operations Center. We quickly identified that there was no one incident commander that could handle this type of response. So we moved the organization to a unified command group, which had never been done before. So it was a matter of educating executive leadership as to what that was. And then we had emergency support functions that comprised the Emergency Operations Center. They had never worked in that function before, but we quickly moved the emergency support functions into work groups. So we had 21 ESFs that worked in 14 different work groups, and that's the way we ran the exercise. So next slide, please. What it did was enhance our ability to make decisions and execute change. And I talked through this, so we could move to the next slide again. So this is just a quick, for those folks that are on that may know me or have worked or I've worked with before, you know that no good idea goes without a good whiteboard. This is what the whiteboard looked like pre-COVID. and it stayed pretty close to it during the response. We could go to the next slide. I'm going to start going through these slides quickly because we don't have a lot of time, and I have a couple of slides that I do want to delve into. So our activation triggers are any major impact to one or more hospitals, smaller emergent impact to 2 or more hospitals, or a catastrophic response at the city, state, or national level. Next slide. These are the 21 emergency support functions. I've asked that these slides be made available if anybody wants to see them, so we could move past this without me reading through it. Some critical issues and resolutions. These, I think, are the next slides that I'll delve into, and then we can talk about after all the other presentations if there are any questions. So next slide. All right, so the issue here was patient surge overwhelmed immediately available brick and mortar capabilities. So very quickly, we had to work with engineering, supply chain, information technology, infection prevention, operations, finance, clinical and medical capabilities, and staffing to come up with what we could do outside of the brick and mortar and how we could encompass areas that were really not identified for surge inside the hospitals. We used Blue Med tents, which gave us isolation capabilities, and we used them in many different ways, many for triage, many for testing, but we were going with unknowns at that time, so we were doing the best that we could. We go to the next slide. Patient needs overwhelming available capabilities, critical care and negative pressure capabilities. Engineering did yeoman's work. At one hospital alone, the Mount Sinai Hospital System, the lead hospital, we transitioned 10 adult units to COVID-19 ICUs, 94 licensed beds to 240 adult ICU beds. We double occupancy ICUs, converted 260 patient rooms to negative pressure using HEPA exhaust fans. That was really done on the fly. Incorporated remote patient monitoring and point of care monitoring and expanded inpatient telehealth and consultation. Each one of those bullets and countless more were really done on the fly with an idea that was matured and implemented with very, very little hurdles, because the unified command group was made up of the chief operating officer, the chief medical officer, the chief information officer, and the chief clinical officer, as well as emergency management. So decisions were made within minutes to hours and not days to weeks. Next slide. We identified that we needed more space than we had the capability for. This is the main lobby that had a Starbucks, a grand piano. We moved everything out of the way and created 57 isolation rooms within that lobby. Next slide. We also partnered with an opportunity that came through us from New York State to use and work with Samaritans Purse. It's their first domestic response. They're an international organization that does care outside of the continental United States, and we were able to bring in an additional 68 medical beds by partnering with them. Next slide. This is a layout of what the Samaritans Purse looked like in Central Park. Next slide. That was the exterior layout. The interior of the facility gave us things that, working closely with Samaritans Purse, who had tremendous experience and exposure through Ebola responses. They taught us many things, and we worked together as one. We actually made this field hospital the 9th hospital in the Mount Sinai Health System, so that we were able to move patients back and forth. Next slide. We had federal assets that came on board. The Comfort, as many know, took on 182 patients from around the city. The Javits Center, 1,100 patients. There was a lot of learning that went on there, that there's a lot of opportunity for us to improve on as we continue to work with our federal partners. Next slide. Staffing was a key component for us. What Samaritans Purse brought was their own staffing, their own medications, their own PPE, but we used ambulatory care sites as we closed them to bring our staff into the hospitals. And we also did expedited certifications and licensure for many volunteers from around the country that came in to work with Mount Sinai. Next slide. And then we built beds and capacity, staffing deployment and cross-utilization. I am out of time. I want to make sure that we covered this by just saying that we credentialed many people in short order, and that worked for us. We used external staffing services and anybody else that we could actually find. And then we had experience where surgeons were working as nurses because their level of expertise in surgery was not required for a COVID response, but because they were dedicated professionals, they wanted to do something. So we were teaching people on the fly the skill set that we needed to be able to do the job that we had in front of us. Next slide. And then this is just the next couple of slides we're going to go quickly through because I'm out of my 10-minute block here, but we were burning through every critical use item and using the unified command group and the supply chain and inventory to be able to find, acquire, and then utilize with infection prevention and occupational safe and healthy regulations was a challenge, but we worked with communicating what we needed to do with our staff so that everybody was on board with us giving them the best that we could find and then moving forward as we designed and developed policy and implemented it. Next slide. We did, and this again, I'm just going to touch on what we ended up doing as one of the crisis standards of care implementations is we identified red, yellow, and green areas. Green areas didn't need to switch out PPE. Yellow had to for certain patient use criteria, and red had to switch out every time they had new patient contact. That was a departure from what we usually do, but it was well received and worked well for us. We can move to the next slide. And then communicating rapid decisions was very critical. We continue to work on it. It was one of our findings in our after actions. We did a lot of new policy and a lot of new procedure and pushing that out with people that are very worried and concerned about their safety, the safety of their loved ones as they go home after a patient care engagement was key to us and very essential, and needs to be remembered in any environment where we're under stress, doing things that we don't normally do, asking employees and staff to do things that they don't usually take on, communicating those changes with a rationale and an emphasis towards their safety is critical in success. Next slide. Patient movement and resource allocation I touched on earlier. We were fortunate to have our own internal EMS capability as well as our own transportation command center. So we were able to move patients freely throughout the 8 hospitals and where we needed to decompress certain sites before they really came to their knees. Next slide. Then what one hospital did, and we all took it up, was they started playing "Here Comes the Sun." As patients, COVID patients, were successfully discharged. Well, the reason that became so important was obviously to celebrate the fact that patients were leaving the hospital successfully, but it was very uplifting for all the staff throughout the hospital to know that when they heard that song, another patient was successfully discharged and not a victim or had succumbed to the disease. So, Dick, I'll hand it back to you.
Thank you. Don, great presentation. Folks, I can tell you, I've heard longer versions of some of this, and there's so many lessons that could come out of that Mount Sinai experience. It's a wealth of information. When you get the slides, there's a couple of links on there that you can go explore. One of the slides that he had on there talked about 21 different focus areas, and the one that focuses in the area we're talking about is what's called ESF 8, Emergency Support Function 8. This is the health and medical sector of the National Response Framework. And at the heart of our COVID response is obviously public health. And to that extent, we've got Jim Blumenstock, who is the Chief Program Officer for Public Health Practice with the Association for State and Territorial Health Officers. Many of you have heard the term AASHTO. And Jim is going to talk to us about how public health has helped us to kind of bring this together and work towards addressing a cohesive response to COVID. Jim?
Dick, thank you so very much for that kind introduction and for this opportunity to be part of such an important convening. Next slide, please. So what I'd like to do is, before I begin sort of the heart of my presentation, just tell you spend a few moments telling you about ASTO. We are the national association that represents the jurisdictional health departments of our country. The 59 states, territories, and the District of Columbia are our members, who are the chief executives of those agencies. Most of them are cabinet or sub-cabinet, and they are really the ones that are principally responsible for all the health programs and activities in their jurisdictions, and ESF 8, as Dick had mentioned. Our membership spans 10 time zones, from Palau all the way to the U.S. Virgin Islands, both CONUS and OCONUS. And while technically we're an association of 59 men and women, in practice, we provide leadership support, capacity, technical assistance, and advocacy for the 100,000 men and women that work in those programs every hour of every day. Next slide, please. So, in thinking of how I wanted to sort of frame my remarks, I wanted to sort of start with the premise that a more resilient community is one that embodies the 4 dimensions of being healthier, being more prepared, being better protected, and being more informed and engaged. And I also want to suggest that when I think of the word resilient or resilience, it's, to me, it's sort of the broader of the various definitions you may apply. And this would also include, being able to withstand the assault, such as COVID-19, adapting to it, and obviously recovering from it, and not necessarily in a bounce back, but also in a bounce forward way that could make us better and stronger, either for the next new event or the event like COVID that has multiple waves or phases that could go on for a period of time. Next slide, please. So what I want to do in the 4 dimensions that I talked about, I want to do just a little bit of a deeper dive and give you some examples. So, a healthy community is a more resilient community. So what we've seen in the last half a year or so is really some of the consequences that COVID presented to the American people. And certainly this would be applicable, I'm sure, around the globe as well. First, we realized that as a result of COVID, harm was being created through deferred medical care. And basically, data has suggested to us that on the early stages, when we had the stay-at-home orders and the various lockdowns and the very significant advisories to the general public, that individuals were deferring medical care. Data has basically suggested that in the early days, emergency department visits declined by 42%. And not all of those clearly were unnecessary or optional visits that were not realized. That people were making decisions to be safe from COVID, but possibly risking themselves through other medical conditions without getting prompt or proper care. Recent studies also showed that there was an excess mortality number of cases, about 300,000 compared to this time last year. 200,000 of that was attributed specifically to COVID infection, and the other 100,000 were suggested to be related to either direct or indirect causes of COVID, including such things as avoiding necessary or immediate care for fear of COVID or other types of disruptions of services and societal needs that basically had a potential consequence on human health. Another example is in the early months of COVID, there was a measurable decline in the number of routine pediatric vaccine ordering and administration seen across the country. Again, parents making decisions not to take their children to the pediatrician or other physicians for the vaccines, either because there was, again, disruption in service, or there was concern about going out in general public during the stay-at-home orders. And then more recently, and actually currently, is the concern around twindemic. We are in seasonal flu season. So there has been a tremendous push to ensure people not only practice safe practices, but also take advantage of the seasonal flu vaccine for a couple of reasons. Because again, if keeping everyone safe and healthy from flu clearly would improve individuals' ability to recover should they be co-infected with COVID virus, in the future. And also, the less disease and illness we have in a community, the less burden or drain it has on the healthcare system. So they could really focus their priority attention to those that have come in with more severe COVID-related infection, hoping not have to worry about influenza illness as well. Next, please. So the second, dimension, if you will, is a prepared and ready community is a more resilient community. And this is really the heart of public health preparedness and response, the capacity and capability to carry out essential response activities in something as historic as the COVID-19 pandemic. And I just want to quickly go through with you some of those key activities that public health is mobilized to address. Contact tracing is first example. The practice of contact tracing has been applied for decades, sort in small numbers and for such diseases as sexually transmitted diseases, tuberculosis, another example, but certainly not at the magnitude that we are seeing. Our association, along with others, estimated that the public health workforce in this country needed to be bolstered by about 100,000 individuals to carry out the level of contact tracing predicted as associated with the pandemic to basically suppress any outbreaks that would occur from community to community. So the building of that that add-on or additional infrastructure is a work in progress. Clearly there are tens of thousands of new public health professionals out in the field doing that type of work in their communities. It's not without challenge. Because obviously the society that we have, this is a voluntary process. So encouraging people to be open, candid, and allowing for the process to take place so that we can interview and find individuals who could have been exposed to cases is critically important, and we continue to work on that every day. Another example is testing, not only putting testing services or opportunities out throughout the community so people could get a sense of their infection status, but also building up the laboratory capacity necessary to accurately detect this novel new virus. Techniques and procedures that have not yet been put in place to identify COVID-19. And so, sort of starting from zero, so to speak, around the first of the year, to date, we are basically, in mid-April, we were, when we were starting to ramp up, we were doing about 200,000 tests per day nationwide. Today, we have the capacity to test over 1.2 million people a day. And since early this year, over 100 million tests have been conducted with a national positivity rate of around 7%. And of those tests, 6.5 million tests alone were done in the state and local public health laboratories across the country. So you can kind of get a sense of how to really build out that infrastructure, new technology, innovation, development, and really trying to put everything in the field so we could get accurate, reliable, and timely analysis. Areas of infection prevention and control, and this is not only community-based, but this is also healthcare-based, sort of in Don's wheelhouse. The issue of practicing proper infection prevention activities to ensure that healthcare workers, number one, don't get infected themselves in caring for individuals, or they don't transmit disease from patient to patient that they're caring for. And certainly this was a significant issue in the nursing home industry across the country in the spring and summer months when we were seeing major outbreaks. And then the last one is obviously community mitigation. Trying to really educate, train, and equip every citizen to know what the right thing is to do to protect themselves and their loved ones and their communities using common sense practices to stop the spread of disease. Next, please. The third category is basically a protected community is a more resilient community. And I've listed here 3, but there's actually 4 that I want to touch on real quick. Number 1 is obviously vaccine. A daunting, historic, monumental campaign that we're on the eve of launching with the expectation that multiple candidate vaccines, brand new, could possibly be approved or authorized in a matter of weeks by the FDA for use. putting them in the field, recognizing that it's a very complex and challenging activity. There are material handling concerns, such as some of these vaccines will need to be stored at -80 degrees Celsius. They may need to be reconstituted before administration. Some of these vaccines most of these vaccines will require a second dose. So to ensure that everyone who gets the first dose gets a second dose of the same type of vaccine, and then there's proper reminder and recall and tracking to ensure that that final step does take place. And the list goes on, including the logistics of dry ice, of how to keep ultra cold storage, supply chain compliance. So there are multiple activities. I'm sure we'll talk about this a little bit later. Another role of public health is that of therapeutics. When you think back of H1N1, it was all about antivirals, and now, during anthrax, it's antibiotics. Well, for COVID-19, the concern again about antivirals, such as remdesivir, other types of therapeutics in development, such as monoclonal antibodies. All of these are scarce therapeutic medicines, and the public health system is part of the ethical determination of how these scarce allocations will be allocated, administered, and managed. So again, this is a great example of how the public health and healthcare sectors really coordinate and become one to ensure that safe, equitable, and appropriate medical care is treated that would be in the public's best interest. All of this with the goal of closing or ending the disparity gap that we clearly see, that there are certainly segments of our communities and our populations that are at greater risk of COVID and other diseases because of where they live, where they work, and their exposure potentials. And the other topic I just want to talk about is the issue of workforce protection and the workforce resilience. This work is hard, it's difficult, and this is not the only crisis or threat public health has to face on a day-to-day basis. And what ugliness COVID-19 has really brought out in our society is the level of threats and abuse the public health profession has taken over the months because of what they're trying to do to protect their communities. So much so that, you've seen the news clips of different stories around the country, but just giving you one example that, for the National Governors Association to issue a policy brief or an issue brief to their members, basically bringing this to their attention and giving advice to the governors of how best to support and promote good public health by emulating proper public discourse, I think is clearly an example of the importance of really supporting the workforce sector in our country. And the last item is obviously an informed and engaged community is a more resilient community. So as we really work to try to increase the uptake in vaccine when it becomes available, because vaccine is one thing, but the goal is to have vaccinated public. Addressing such things as the historic trauma and public mistrust that we're concerned about, countering mis and disinformation that clearly is circulating. And the two links that I provided there are just examples of initiatives currently underway to accomplish that objective. So in closing, if I could just go to my last slide, please. So what I want to do is first thank you. Mention to you that on our website, we have tremendous resources that serve not only our members, but also the members of the general public. And again, always to encourage you all to be ambassadors of public health by encouraging everybody to follow those mitigation practices of washing hands, wearing a face mask, and watching your distance from others. So thanks again for this opportunity.
Thanks, Jim. Great presentation, folks, and a good summary of what public health has been trying to do to help us get ahead of the curve as much as we can. I think that we heard references to it in his presentation and in Don's presentation as well, the challenges that we've had throughout this thing of dealing with the need for regular and reliable sources of supplies to help protect the public, protect our healthcare workers, our emergency responders, and others. And to address that is Linda Rouse ONeill, who's the Vice President of Government Affairs for the association that essentially represents many of our healthcare distributors that are out there working to fill that gap. Linda?
Thank you so much. Thank you to everyone who's listening, and for thinking of Haida today to being part of this. We're thrilled to be part of this presentation. So on this next slide, what I wanted to do is pause for 1 second. So Haida, as Dick mentioned, we are the National Trade Association for Medical Product Distributors. There is about 100 or so Haida members. They've got about 500 distribution centers scattered throughout the country. 250,000 employees who have been working around the clock to help support our healthcare customers. And that healthcare customer is really the entire continuum of the healthcare. We've got acute care distributors who focus on the physician market or the alternate site market, lab distributors, and then post-acute. And it is really a different mix of distributors who tend to focus on a specific provider market. As you can see from this graphic in front of you, it is a very different model and cost to serve those various healthcare provider settings across the continuum. And I think what's important to remember, and this is going to kind of play into a little bit of availability of some of the products, is when you think about distributors serving those markets, they know those customers inside and out. They know what their general product mix is on a regular basis. And when we start talking about PPE and especially N95 masks, you got to keep in mind that your physician offices and your nursing homes don't ever use N95s in a traditional setting or services, et cetera, that they do in those settings. And so bringing on new customers when there's a pandemic and working with those distributors who didn't probably have contracts for some of those specific products because they've never been used before in those settings is something to keep in mind going forward. And I think people did their best to accommodate and work for their customers. But it's just something to keep in mind when people have been asking those questions of why did nursing homes not have enough? And I think that's something to keep in mind, that they don't traditionally use some of those products, which means they weren't set up that way from a contract perspective, and neither were their distributors. So on the next slide, as an association, in case you want to go deeper on any information on medical surgical product distributors, what we do, how we do it, the value that we bring to our customers. We've got all sorts of infographics, et cetera. We've really revamped and revised a lot given COVID and the scrutiny on the supply chain and a lot of the questions about who we are and what we do, and also what we don't do. The graphic in the middle, I'll call your attention to, and that's distributors versus brokers. And we'll talk about that in a couple minutes, about those folks who aren't traditionally in the healthcare supply chain and companies who are popping up left and right overnight who didn't have any healthcare experience, and were promising to be able to provide product. And people were losing millions of dollars signing up for these kind of fly-by-night brokers who weren't able to then deliver. And that last infographic, I think, is something to keep in mind too, if you're interested when we're talking future solutions and what we need to be doing to better prepare going forward. Stockpiling is great, but there are some things to keep in mind of like how you stockpile and at what level. There was different conversations amongst different states about requiring providers to have 90-day stockpiles. And that last graphic shows you that for a typical hospital, a 90-day supply of PPE would need a football field and a half of storeroom, and then the ability to refresh and replenish it. And so you're trying to do that for every single provider. That gets complicated very quickly, and real estate is expensive. And again, it's something to keep in mind so that when we're thinking forward, we've got the opportunity to be a little bit more strategic in how we might stockpile and how that could possibly look. So on the next slide, I've been at Haida for 10 years. I've been working through several pandemics, and you see those first two bullets. That happens no matter what the crisis is that we're facing. You have that unprecedented demand spike, and you've got non-traditional demand. And what I mean by that is, if you remember when I said in the beginning, Haida members are servicing healthcare providers. Our customers are the hospitals, the doc offices, the nursing homes, et cetera. It is not your average public. It is not necessarily other essential workers. You think about food safety, and you think about airlines, and think about other essential workers who people wanted to be at work to be able to provide those essential services, who are trying to access the healthcare space. And even to some point, some of the state and local public health agencies who aren't necessarily buying on a regular basis and aren't necessarily customers, that we still think of that as some non-traditional demand. So when you think about the unprecedented demand from our customers, and then the non-traditional demand who had every right to be asking for PPE, but weren't necessarily our current customers, that created a dynamic that's very hard to catch up to. And then you've got the opportunistic marketplace, which has been a little bit more prevalent in COVID. And then you've got the COVID-19 uniqueness of the major shutdown of a PPE source in China. Everybody remembers Hubei province was where the coronavirus was first detected. That is also a major source of PPE for the US. And so distributors and suppliers always account for the Chinese New Year. We know that's going to happen every year. We know that shuts down. We know we've got flu. We ramp up in the summer, getting ready for the flu season. We ramp up orders to get more product out of China before the Chinese New Year. And then COVID-19 happened, where you had the unprecedented shutdown and workers weren't able to get to work, and those factories stayed closed for a lot longer than the Chinese New Year would normally have allowed itself. And that created a huge supply problem. And so when you get to the next slide, you've got the supply problem that we just talked about, and this highlights H1N1, N95 mask usage. So 500% increase sounds huge, and it was, but it didn't last as long as COVID. And a couple things to keep in mind from a distributor perspective: we take ownership of that product when we purchase that from the manufacturer for our customers to fill those orders. Which means when H1N1, which didn't end up being nearly as problematic as COVID is, and the crisis is over, it was the first thing that happens is orders get canceled. So my members were sitting on N95 masks for 4 or 5 years before they were able to rotate that through their normal channels, because they were sitting on that product, because orders get canceled and it's very hard to tell your customer, no, you need to still take that. And so again, that's something to keep in mind, and that's a 500% increase. So when you go to the next slide and you look at COVID demand, and this is a snapshot that Premier did, their group purchasing organization. If you're not familiar, they really kind of negotiate contracts on behalf of their hospital members. And this is a snapshot of demand that they did with their members back in March. And that's a 1,700% increase in demand for N95, and that's for hospitals. So when you add in nursing homes, and you add in state and local public health, and you add in other essential workplace but non-traditional demand for the healthcare supply chain, those numbers are just astronomical. And you have the shutdown of Hubei province. However, I'll say one thing: the supply chain, while we certainly need to be robust, they responded big time. We have, for this first 6 months of 2020, delivered a 24% increase in PPE specifically than what we did in 2019. So that shows you that there is that ability to flex and expand. But that 24% increase for the first 6 months of 2020 does not come close to closing some of the gaps in demand. And the problem with COVID, as we all know, is that demand's really not going down all that much as we continue to see hotspots and rises in cases. And I think that just helps kind of paint the picture of the unbelievable demand and the sustained demand that we've got from COVID, and the fact that it's global. Regardless of how well the supply chain has been able to flex and work on behalf of their customers, that demand's not going away. On the next slide, and I will try to wrap up in a couple minutes, I know we're getting tight on time, is, I mentioned the supply chain must be more robust, and we really need to focus on the domestic surge capacity. We need to support that, we need to expand it. There is PPE made here, but we are very dependent on foreign sources as well, as everybody knows, and that sourcing must, in addition to domestic surge capacity, we need a more diverse sourcing opportunities. And then we need to align those supply chains to the end users, and that really is aimed more at that non-traditional demand. We need to be clear: what is the healthcare supply chain going to be responsible for? What is that public health going to be responsible for? And where are people going to be able to expect to get their product if this is going to be, a continuation of COVID, and how do we do a better job for the next pandemic? On the next slide, a couple things I wanted to leave you with in terms of our vision and the work that we've been doing on that longer term solution is, I think where I've wanted to pull my hair out of my head, if I can kind of say that, is people are like, oh, supply chain, why have we not been paying attention to it? And like, we have been doing a lot of work with the stockpile, with the critical infrastructure program at ASPR. We've got a lot of great work streams going with them. And we used the reauthorization last year, the Pandemic and All Hazards Preparedness Act, as an opportunity to actually to keep those work streams going for the future. And that was around understanding commercial market response, free entry, understanding the ancillary product availability, so the needles, the syringes, et cetera, that's in the commercial market, and identifying substitutions. And that's in the hospital preparedness program. For the first time, it included a supply chain assessment that needed to be done by the grantees to be able to keep that federal funding going forward. And so the first time we had supply chain and a federal reauthorization bill for public health programs, we had it incorporated at the state and local level for those HPP grantees. And then COVID hit, so we didn't get a chance to implement a lot of that groundwork that we had already done. And then what we've done this year, on the next slide, is taken the opportunity, I think, to tie a lot of that together in even a bigger way through the Medical Supplies for Pandemics Act of 2020. It's bipartisan, it's bicameral, it's been passed numerous times by the House and Senate in their various COVID deals throughout the summer and fall. And if we can get a final deal, I feel good about where we would be. But it does two things. It directs the SNS to work with distributors to manage a cushion of critical products like PPE, like testing swabs, like wipes, things that we do on an everyday basis that's used every day in healthcare. And then it directs the SNS to work with manufacturers to diversify production, increase capacity. And we've wrapped all that up on the next slide. On our white paper, this is a little bit longer, but it hits those four key components. Utilize distribution for that forward deployed critical cushion, diversify the manufacturing, and that end user alignment, I think, is important too, so that everybody's pulling down from that same healthcare supply chain. I'll leave you with a graphic, as I know we're close to time, of how we would envision that looking. So it takes kind of that white paper and that domestic cushion, or PPE reserve, as it's called here, but it's not really just PPE, it's those critical products that you need regardless of the event going forward. And that, I think, really brings the best of the federal government and the commercial market together for that longer term solution that we need going forward. I know I talked fast, so happy to take questions or follow up with anything else you need.
Dick, you appear to be muted.
Sorry about that. Linda, I assume that the white paper is available on the HIDA website if they wanted to go find it?
Absolutely.
Okay, great. Folks, we're going to open up and hit a couple of questions for each of our callers or each of our participants. And I'd like to start back with Don. And Don, we had a little sidebar conversation about this yesterday, and I think it's important that you talk a little bit about what you think are some of the things right now that healthcare organizations need to pay attention to going forward as they prepare for a coming surge.
Thank you, Dick, for the question. I think of all of the things, and there are many, in each, both Linda's and James and my presentations that can be identified, I think the one thing that we're most concerned at Mount Sinai and we're working on as aggressively as we can is supporting our staff, not just the medical staff, but all staff, with regard to dealing with the ongoing stress and pressure, the consequences of the COVID response, what they were asked to do, what they had to do. There's a tremendous amount of pressure on the employees. We're trying to support them in every way possible. We have ongoing weekly sessions in terms of leadership, in terms of stress management, in terms of provision of therapy and therapeutics. I think that the biggest focus for us right now, as we continue to get COVID patients on an ongoing basis, is to help our staff stay as healthy mentally, physically, and emotionally as possible. And I think that that's going to be a burden for us across the nation and across the globe as we continue to deal with the consequences of this virus.
Absolutely agree with you, and I'm hearing that from my own healthcare organizations here in Kentucky. Jim, without getting into the politics of this thing, and this is a tough one, this vaccine that we may or may not get here in the next 30 to 60 days, different models, different scenarios. We've seen in the playbook at least 3 or 4 different scenarios, some logistical challenges. What do you think are some of the most significant issues and challenges that we're going to be facing as we try to successfully get a vaccination campaign going out there?
Yeah, thanks, Dick. And again, this answer is not censored for any any political concerns. I mean, I think this is clearly recognized by so many professionals, and that's the issue of achieving the appropriate level of public confidence and trust. Trust in the system to do it right and do it well, and confidence in the product that it's safe and effective. So it's messaging, it's risk communications, it's the issue of public engagement to have them part of the process as we determine distribution strategies. The transparency that allocation is done fair and equitable and ethically. So that is a huge responsibility and burden on the public health and the U.S. government whole of community effort. And I think that's going to be the key to success of all of us working together to have that level of transparency, openness, and fairness in this process going forward. So we have the vaccine that actually could become a critically important asset as we try to fight this, this historic disease.
Dick, looks like you're muted.
Linda, I want to get back with you with a final question here on supply chain resilience and stockpiling. 90 days was in your slides. Some people are talking about 30 days. We've got that challenge of just-in-time delivery. My own state, where they were talking about 14 days, and I said, no, 14 is nowhere near enough, guys. You've got to have at least 30, I would think, out there. What are your thoughts in the system within your association about how to handle some of this stockpiling challenge?
I think there's two things. I think it's when you stockpile. We're still in the middle of response. There's still hotspots, and so we want to be able to serve those customers who are in the middle and still taking COVID patients and protecting their healthcare workers. So I think sometimes it's hard to put things on the shelf when you also still need them on the front lines, and I think that's going to be an ongoing challenge on when. I think the how. I think what we see it as a supply chain is that bigger cushion that we help manage with the stockpile on behalf of our customers. Because that first call is to the distributor for more product, right? We're going to call the distributor if they need more product. So if there's that cushion in our white paper, we talk about it being kind of, like 60 days, 30, 60, 90 days. And I think that might depend on the product. Some, that ramp up is quicker. Maybe you don't need to have 90 days of everything. Maybe it's some that only need 30. And I think that comes back to that little bit of a partnership on how much of each do you need in that cushion. But you need to understand how that ramp can happen on the back end and fill. Some are going to be a little bit easier or quicker depending on that supply chain than others, but you need that 30, 60 day out there in the national level and dispersed between the distributors to be able to respond. And I think that's a when, and that's a longer term. And I know why people are doing it now, but it's hard as we're still trying to help people on the front lines, and demand is still high.
Hey, Dick, I'd like to just jump in, and this is an issue for both Linda and Jim and myself in all the aspects we just discussed, but that 90-day requirement is set upon us as a hospital system by the state, and they're actually assessing the competency based on our affirmation that we have that. So we are actually seeking and using warehousing capabilities that will probably add up to what you said in terms of, the size of a football field plus. It has not been easy, and in many areas we're still struggling to find that capacity and that inventory to make that mark.
See, we aren't at that in my state. We're talking about having a minimum of 14 days before you do something with elective surgeries, and I'm saying that's not enough, guys. You've got to get beyond that. I'm pushing for at least 30, and I appreciate that. Folks, we have run out of time. I think this is clear that we could have gone on for at least another hour. We've got great presenters here, a lot of good timely information. Each one of these could be developed probably into its own segment or its own program, but we do need to wrap up. I want to thank Don, Jim, and Linda for your excellent presentation. I think we've done a good job here of, unfortunately, just hitting the high spots for a very complicated issue. And I think we really do appreciate everybody's participation today. General, we're going to turn it back to you now, sir.
Thank you, Dick. I appreciate that. And my hat's off to all our presenters and you, and also Avi just a wealth of information, a lot of great lessons learned, and really some nuggets of best practices that we will make a point and share with the communities. Just a couple of closing remarks. You've got a couple of days left if you're interested in playing EarthX this year. There is a health and medical lane that I would encourage you, if you haven't heard about it, jump in, register, and go play. We'll be concluding that at the end of the month. So you've got about 3 days left to get in and do that. It's been a tremendous success. Over 14,000 people have played this year. So jump in and make the most of the opportunity. I want to end talking a little bit about the Global Resilience Framework. Our target through the Commission webinars is to develop this shareable resilience framework. We're going to take the lessons learned and the best practices and put them into an easy to consume volume that will continually evolve as we learn more as we go forward. So stay in contact with us. The best way to maintain contact is to continue to register for our webinars and to register for EarthX. We will consistently communicate with those groups. But the resilience framework will be released in late January, along with another couple of really important documents that will be finalized by that time. And then going forward, I just want you to kind of put this in the back of your mind. There is a little bit of a typo on this slide, and it'll be corrected in the email that goes out. Our next GRCOM webinar will be on 3 December at 11 o'clock, and we're very excited. We've actually had some very senior representation from Congress agree to present, and it will be on leadership, communities, and strategic risk. And what the Commission is going to focus on is the resilience requirements for the new world. It will be international. Lord James R. Buthnot, who's now in charge of risk strategy for the UK, is going to be one of our hosts. And as I mentioned, Congress is invited and has already accepted a speaking role. So again, that's 3 December. We're not going to go back in time, just a typo on that slide. So feel free to register. I appreciate, again, everybody who made an effort to be here today. We have a significant number of people that registered to watch the video. We will send out a copy of all the slides. We will send out a link to the video that you can watch on demand and download it. And one more time, my hat's off and my sincere thanks to Dick for his facilitation, but to Don, Jim, and Linda for just some outstanding presentations. You will get the links to some of the material in those slides that come out, and I encourage everybody to stay tuned, become part of the Commission. We'll actually send something out probably next month on how you can become part of the Commission, and we look forward to continuing our journey with you together. With that, thanks again to everybody for your time today, and I'm going to go ahead and end the webinar.